Thank you. My name is Taylor Riall, and I'm the current president of the Society for Surgery of the Alimentary Tract, and I'm a pancreaticobiliary surgeon in Tucson, Arizona, and I'm looking forward to visiting Mexico City. In May of 2024, we held our 65th annual SSAT meeting, and I've been asked to present the best of that meeting. There are many topics there to discuss, and I decided to focus on pancreatic disease, and I've chosen 3 topics, which encompass 6 abstracts presented at the meeting. The topics include adjuvant therapy after neoadjuvant chemotherapy in pancreatic cancer, quality of life, decision regret, and patient priorities after pancreatectomy, and exercise and anti-tumoral immunity in pancreatic ductal adenocarcinoma. The first study is from the Mayo Clinic, and it evaluates the impact of additional adjuvant chemotherapy in patients with pancreatic cancer who have undergone neoadjuvant therapy. With increased utilization of neoadjuvant therapy for pancreatic ductal adenocarcinoma, even for upfront resectable disease, it's important to ask the question, who benefits from adjuvant therapy? In this paper, they specifically used the United States National Cancer Database, and they include over 7,000 patients who underwent neoadjuvant therapy and surgical resection with pancreatic ductal cancer. They're trying to identify groups that benefit, and they compared outcomes in 4 groups. Those with no lymphovascular invasion or lymph node involvement, those who had lymphovascular invasion and no lymph node involvement, those without lymphovascular invasion and with lymph node involvement, and those who had both lymphovascular invasion and lymph node involvement. They found no benefit even in the highest risk group, and will present the data in detail. The next topic is a topic that's an area of interest for my lab, and this includes quality of life, decision regret, and patient priorities after pancreatectomy. Interestingly, there were 4 abstracts on this topic at the annual SSAT meeting. The indications for pancreatic surgery include benign disease, premalignant disease, and malignant disease. And regardless of indication, pancreatic surgery has significant impact on patients' quality of life. The average length of hospital stay is 7 to 10 days. There's a 40% major complication rate. Patients often don't return to their baseline functional status and sometimes can't be cared for at home. And even with even without complications, pancreatic resection leads to long-term symptoms, including indigestion, altered bowel habits, diabetes, exocrine insufficiency, and decreased energy, all of which impact quality of life. This is really important because patients with benign disease are often asymptomatic prior to surgery and can have possibly worse quality of life after pancreatectomy. In patients with diseases like chronic pancreatitis, they're often symptomatic, but alleviation of symptoms is not guaranteed. And in patients with malignancy, even with optimal treatment, survival is poor. They don't tolerate chemotherapy well. It requires a lot of time to receive care with minimal survival benefit. As surgeons, we provide evidence-based information on resectability, responsiveness to chemotherapy, surgical technique, complications, and survival. However, we lack information on quality of life. What is their ability to function postoperatively? How does their quality of life change over time? Do patients who have pancreatic cancer and recur have decisional regret? We believe this information is critical in helping patients with pancreatic cancer and other pancreatic diseases make decisions aligned with their goals of care. There are 4 studies presented at the annual meeting that help address this question, and they'll be presented. Finally, I'll present data from a paper that I really enjoyed entitled Exercise Stimulates Anti-Tumoral Immunity in Metastatic Pancreatic Ductal Cancer. Previous studies have shown that aerobic exercise is protective against localized pancreatic ductal cancer. The majority of patients we see are metastatic at presentation and survival is low. And given this previous benefit, the authors asked the question, does an exercise intervention provide a similar benefit in metastatic pancreatic ductal adenocarcinoma? The authors generated a reliable model of pancreatic ductal metastases and primary cancers and demonstrated that exercise was associated with decreased tumor burden in both the liver and the primary tumors. Interestingly, also found that this benefit was contingent on the primary tumor being in situ. This work raises the possibility of future clinical interventions, as well as additional questions, and the data were quite interesting. Again, I thank you for your time and I look forward to seeing you in Mexico City.